thank you to all of you who are here and those who are online to help us give this welcome to the CAUSALab Center to Learn what works. See, this is a new center that has been created in the Department of Epidemiology at the Harvard Chancellor of Public Health. And what we do is we generate, analyze, and interpret data to learn what works in medicine, in public health, and in policy. Why do we need to know what works? Well, because we need to make decisions. Decisions have to be made, say, in clinical medicine. Doctors, patients need to know whether to treat with treatment A or with treatment B, whether to treat now or wait, whether to treat everybody or just some people who are going to benefit most from the treatment. They need to decide when to stop the treatment, when to switch to a different treatment. And the same thing in public health. We start a new screening program or a new vaccination program. We need to decide at what age we're going to screen or vaccinate, with which frequency, and at what age. The point is that good decision making is based on good causal inference. We need to know the comparative effectiveness and safety of different courses of action at our disposal to choose the best one. And the CAUSALab will focus on creating actionable causal inferences, inferences that have real-world impact. Our goal is to help decision makers make better decisions. And by decision makers, I mean you, patients, doctors, public health officers, policymakers. The way in which the CAUSALab does that is by combining sound methods for causal inference and AI methods with high quality data that comes from large databases of electronic health records, of insurance claims, of cohort studies, and many different sources of data. What we want is to do research with policy implications. And just to give you some examples of work that members of the CAUSALab have been involved in during this last year, last few months. There was a lot of work on COVID-19 vaccine effectiveness and safety. We'll hear more about that later. But the first pre-award assessment of the effectiveness of COVID-19 vaccine was done in joint work with members of the CAUSALab. There was also a lot of work on methods to prevent mortality of COVID-19 patients that are intensive care units. And then, of course, there was a lot of non-COVID work, work to estimate the health effects of the dietary guidelines of the American Heart Association, work to estimate the effect of changing the surgeon's operative volumes for Medicare patients, and many more. These are just some examples of research with policy implications. In fact, the range of research of the CAUSALab is wide, covers medical areas, from infectious diseases, mostly on HIV, on hepatitis C, COVID-19 now, to mental health. In fact, the CAUSALab is the methods core of LEAP, which is an NIH-funded effort between McLean Hospital, Massachusetts General Hospital, and the School of Public Health here. We also work on cardiovascular disease, methods for the treatment and the prevention of cancer, on diet, on pregnancy, and infertility. And one very special area of work is to help health systems become learning health systems. Meaning a system in which the data that are created by the system as they see patients patients are treated and they are safe, that same data is used to make causal inferences that are used to improve the care of those patients. And the Veterans Administration, the VA in the US, is a perfect candidate for becoming a learning health system. This is the largest healthcare system in the US. It has electronic medical records with clinical data. It has a lot of trials that are done within the system, and it also has the Million Veterans Program, which is the largest multi-omics biobank in the world. So by using all these data, all these different sources of data, we can help the VA as part of this joint project, this known as VA Causal. We can help the VA become a learning health system, and everything that we are doing here will be of use for other health systems around the world. Because we are working with many people around the world. We are the method for the HIV causal collaboration, which is one of the largest consortium of cohorts of people living with HIV in Europe and in North and South. In North and South America. Also, the head causal collaboration is something similar but for hepatitis C. The fed causal collaboration, which is something that we are assembling now, which will be the largest study of people with first episode psychosis around the world too. We have very active research programs with the Karolinska Institute in Sweden, with the National Institute of Health in Spain, and with research institutes in Israel. Besides that, we also do a lot of research on methods, and we do research on gene methods, on target trials, which Dr. will work about now, on transportability, on insulin variables, and Mendelian randomization, on deep learning, IA. We cover a very wide range of methods that are combined with the data to try to answer all these questions that we are interested in. And there is a teaching component to the CAUSALab. We aim at training the next generation of people doing research on causal inference, both on the applied side and the method side. Right now, we're doing that for the students at the Harvard Teaching School of Public Health, and starting next summer, we will be opening a training program for people from outside Harvard. There will be more info about that in the next couple of months. Of course, the most important part of the CAUSALab is the people, and this is a fantastic set of family members, of postdocs, of students and staff, and they are the ones who make this happen. They are the ones who are behind every single project that I do. So the CAUSALab is ready to go. We have good data, we have cutting-edge methods, we have excellent people. We think we're making a difference, and we will continue to make a difference. And it would be good to think about how did this start, because this really starts the current version of what we're doing starts in 1986, when Jamie Robbins described a general theory of causal inference that could be applied to complex longitudinal data with averages. So this seminal paper that Jamie Robbins wrote is the beginning of modern causal inference. And over the next decades, people in the Department of Epidemiology at the School of Public Health, under Jamie Robbins' scientific guidance, they were working to make those methods better, to find new methods, and to apply all of that to the increasingly large amount of data that have been available since then. Fast forward to this year, and the CAUSALab was established because the research program has grown by several orders of magnitude since 1986, and we needed a more stable way of doing this research in a more articulated way. We also were working with lots of partners around the world, so having the CAUSALab USA base, we can do that better, and also we want to develop new training in proper Inference, which will be, as I said, one of the tasks of the CAUSALab. I may not have been convincing enough to some people who may still question why we need something like the CAUSALab. Why not contact us? Trials. We want to make causal inferences, great. Let's do a lot of randomized trials, right? That'd be nice. That'd be very, very nice. But it will make our life much easier. But unfortunately, that's not how it works. That is not possible. We cannot do that. We cannot do trials for a lot of very important causal questions. Sometimes the trials are too expensive. Sometimes the trials are not ethical. We would not do trials to look at the effects of cigarette smoking. Sometimes the trials are not right. Where we want to estimate the effect of eating fish 3 times per week for 2 years, we are not going to be able to convince hundreds of thousands of people to eat 3 servings of fish per week for the year. So we cannot do that trial. And then many times the trials are going to be done, are possible, and they will be done, but not instantaneously. So the time that we decide that we need to conduct a randomized trial, we design it until the time that we will have the results, that will be a period of months or years. And in those years, we still need to make decisions without trials. So that's what we need causal inference from observation. For all these large and not so large databases that are at our disposal, is because really there is no alternative. We want good policy. So we don't do causal inference from observational data because we love it, but because it's the only thing that can be done in the data. If we want evidence-based decision making, then we need to use the best possible evidence. We need to use observational data in the best possible way. And one way of thinking about how to do this is to use the observational analysis to emulate those randomized trials that we don't have or we would like to have. We can still think of those trials as the target of our inference, and now we need to use the observational data to emulate the target trial of interest. So that's how we learn what works and what harms. We use data that was not generated as part of the randomized trial to try to mimic trials. And in fact, we can think about causal inference from observational data, a lot of what the CAUSALab does, as an attempt to emulate some target trial. And we can go even further. We don't know what the target trial is. We know what the factor contrast is. That's a different way of saying it. Then we probably don't have a very good question. This concept of the target trial has been with us for a long time, at least since the 50s, by different people who have been working on this topic. But it wasn't really until 1986 that the concept of the target trial, as explained by Jamie Robbins for complex data with time-varying treatment, became really relevant for a lot of policy decisions. And the CAUSALab is leading the way in target trial emulation. We have done this in different ways. One way in which we have studied these methods and this approach to causal inference is to look at classical failures of observational inference, of causal inference from observational data. Some cases in which the observational studies did not come with the correct answer because they were prove it wrong later. In each of these cases, and we have a series of papers in the literature, we have replicated the biased estimates, and we have explained why they have, essentially because the emulation of the target trial was not correct. And then we have showed how to fix the problem. Essentially, using exactly the same data, you can get the right answer by correcting, emulating a target trial. These are types of post hoc things, and we are also working in a more constructive way, as I will explain now. But this discussion about randomized trials versus observational studies is really boring. It's boring because this is not about one type of design versus one method for causal inference versus the other. We need both, and they are complementary methods. So what we need really is to be able to use the best of both worlds to make the best possible policy decisions. And sometimes we will have the randomized trials only. Sometimes we have the randomized trials before the observational data. Sometimes we have the observational data before the trials. And sometimes we only have the observational data. When we have the randomized trials first, then we can use them to guide and to improve the observational analysis. We refer to that sometimes as benchmarking. Then we use the observational analysis to answer questions that the trial couldn't answer. And there are many examples of these that people at the CAUSALab have been working on for questions about the effects of antiretroviral therapy in the early period of HIV, questions about fertility treatment. That is now an active research program on expanding results from trials of fertility, and of course, in this last year, questions about COVID-19 vaccination. We have a trial that was conducted in 2020. It was relatively small, say 40,000 people, and now we want to know more things. We want to know what is the effectiveness in different age groups, in pregnant women. We want to know how the effectiveness changes in the Delta period. We want to know what are the effects of boosters, and of boosters by age group. Randomized trials are going to be limited in trying to answer many of these questions, but we can use observational studies, and we will hear a talk about that very soon. Now, there are times when it is the opposite, when the observational studies come first. And then we can use the results from the observational studies to guide the design of future trials. Again, there are many examples in which the observational studies came first, and then were confirmed by trials. And there are examples for therapy for HIV, in which data from observational studies were used to change clinical guidelines, and then there were some trials that confirmed that. Or in the last year, there has been a number of observational studies that have studied the effect of treatments for COVID-19. For example, there were studies in the first half of 2020 that showed how tocilizumab was beneficial, and that was confirmed by trials 6 weeks later. There were studies that showed that anticoagulants were not beneficial, and that was confirmed by trials. There were the use of coagulated plasma, and we will have a talk about that. There are also some cases in which we have done the observational studies, and we don't have the trials yet, because the trials take 10 to 15 years in some cases, like for cancer screening trials. So we'll see soon, in a couple of years, whether the observational studies work or not. The point is that the CAUSALab is working to unify causal inference. It's not more arguments about the track lists and the observational lists about which method is better, what you can track. Let's try to work all together using the same methods. We are going to analyze the observational studies as if they were randomized trials and vice versa when it is appropriate. And in the next session, you'll see a few examples of our approach. We have chosen 4 examples in which that are based on COVID-19, because it's something of obvious importance now, and they will give you an opportunity to see how we are working and of course to ask questions to help us improve. Because one very important question here is, how do we know we are right? That's really our meta question. For everything that we do, is how do we know that this is correct? We have a full session this afternoon to talk about that. Jeff Robbins will start with a brief discussion, and then there will be a panel. And along these lines, I'd like to introduce the concept of adversarial collaborations that the CAUSALab is encouraging. See, as I said, we talk the talk of methods, and we walk the walk of going from the methods to the inferences with real world impact. People at the CAUSALab, they really care about issues that are very important to many people's lives. And that means that our work is often used to guide policy or to inform policy, and I gave you a few examples. That's quite a responsibility, and we take it very seriously. It is possible that despite our best effort, we might make a mistake. We invite people who think that we have done something that is not correct or can be improved. We invite you to get in touch with us so that we can establish this adversarial collaboration in which we will work together to try to make it better. Sometimes we will have to re-analyze data, sometimes we have to do different type of things, but we will be working together, and we'll report what we have done in an transparent way, and after having done this in the most efficient way, which is really you think that we can do better, and we will try to follow what you say until we both get convinced that is the best way of doing it. And I want to finish by thanking a few people. The first person I have to thank is Kathleen, who is the person who has been behind everything that you are seeing here. He has done an incredible amount of work to make this symposium happen, and she is really the soul behind a lot of the things that happen at the CAUSALab. I also want to thank Bert Hoffman, the chair of the Department of Epidemiology that you have heard, and thank him, the Dean for Academic Affairs at the Harvard School of Public Health, who were very strong supporters of the CAUSALabs, and without that this would not have happened. And of course, my most deepest thanks go to the members of the CAUSALab, which, as I said, are the people who make this happen. Thank you very much.